Recording in progress.
What we have done is, this is the MCQ of video number 2, Immunology chapter. We reached up to 27. The last one we discussed was about the hepatitis B vaccination at birth. Now we go, now we go in the rest. There are another 22 questions also. Hopefully we'll finish it today. Okay, you read it fast now.
The interval between primary dose of vaccine should be at least 4 weeks, sir.
Okay, that's a very straight answer, 4 weeks. Between two kill the vaccine has to be, to live live ideally is 4 weeks. How early can you give a killed vaccine? How early can you give a live vaccine, Mohsen? Suppose they want to go somewhere.
Sir?
Suppose the
Next
patient's due is today 16th. They come on 12th and say, doctor, we have to go somewhere. Can we take our immunization today? What will be your answer?
Last dose difference will be 4 weeks, or can be 2 to 4 days earlier also.
4 days
At
earlier
least.
for killed vaccine. Have no doubts about this. Killed vaccine you can give 4 days ahead. Suppose they are traveling to Gulf, they want to take the immunization or they have taken for 3 days before, it can be counted. Viral vaccines, that 4-day limit is a must. That's the usual. If it is given before 4 weeks, 28 days, it is not counted. Okay. Read it fast now.
Which vaccine is not affected by maternal IgA in the gut?
Well, does it take so much time?
Oral polio.
Yeah, oral polio. That is one of the bases of the neonatal polio. One of the reasons, among the many reasons why you give neonatal polio and insist on it, the maternal IgA in the gut does not inactivate the virus. Now, next, again, it's all from the IAP book only. You should read it. Okay. Now, 31 question,
Which of the following disease lacks an established correlate of protection?
That is, normally we count the antibody level, especially for it should have been done on you for certain vaccines. For others, there's no correlate of protection. You can't say the titer is so much, therefore you are protected. For titer is less than this, therefore you are not protected. Yes. Which vaccine is that?
We do tetanus, hepatitis also titer. So, sorry.
Quick. Gopika, you are there?
Yes, sir.
Yes, please. Which one?
Hemophilus influenza.
I see. Half of you are sleeping when I am taking the class. I don't know how I can emphasize it more. I told pertussis, I said this is a big problem because there's a big debate in the world whether wholesale vaccine is better or the SLR vaccine is better. And the people get, you will go to any conference, you will find the speaker is probably controlled by the lobby and they say SLR vaccine is equally good. Very difficult to say which one way or the other, because there is no established correlate of protection for pertussis. For hepatitis B, you have tetanus, you have HIV, you have. You must know, because in immunosuppressed patients, you may have to do the antibody level sometimes to see whether the vaccine have to be repeated. Pertussis, there is no correlate. Again, from the purple book of guidebook of immunization. See, when you don't answer these questions, what it means is that you are a DCH student or a DNB student. And the most important book of immunization, leave alone my classes. My classes, I'm taking you to make sure that you know the core of it. You are not reading that book. The purple book, IAP guidebook, you should read from A to Z. Okay. Now, next question, please.
correlates of protections are important for
Comparing vaccine efficacy.
Yeah, casting comparison vaccine. Who is this?
Ashwati,
Gopiga?
sir.
Oh, Ashwati, from where you joined? Where are you now?
Home, sir.
Okay, everybody is at home. Okay. Therefore, the correlate of protection is comparing vaccine efficacy. Now, we had put up a slide. Now you read the whole slide because you don't seem to be sure about it. Can you read, Ashwati, the slide?
Okay, sir. Correlates of vaccine-mediated immunity. A given marker that is measurable, whether the antibody or a cellular component elicited in response to a vaccine that confers the protection against a disease, is termed correlate of protection. Conventionally, due to the uh, relative ease of measurement, it is specific antibody in the serum of a vaccine. Measurement of cellular component is difficult, invasive, and highly cost intensive. The correlate can be absolute. Example, HEP and hepatitis B, which are directly protective, or surrogates, like indirect markers in varicella or rota. Disease such as pertussis, HPV, however, have no established correlates till now. Correlates of protection are important to confirm immunity, compare vaccines, and therefore need to be standardized and replicable.
See, when you joined PRS, they must have done your hepatitis B antibody. Am I right?
Yes, sir.
Yeah, therefore that's one which is normally done. The other correlates become important because we don't important when you have immunosuppressive treatment going on, or we will come to that later when you have when they have done a bone marrow transplant and all that. Therefore, in vaccinology, it is important to know which is available. You will have to find out from the lab which one you should order. For that, you should know the correlates of vaccine-mediated immunity. If I am, you can be asked a short note on that because this is okay. Next question, please.
The birth dose of OPV improves seroconversion by inducing mucosal immunity before entry.
The birth dose of OPV improves seroconversion by inducing maternal immunity before entering interference. That is right, because the viruses have a capacity to fight against one another. That is why exactly two viral virus vaccines were not supposed to be given in our time. But later on, they mixed MMR and they found out there's no problem. Generally, if it's given at the same time, there is no problem. If it's divided over a period of time with a shorter interval of 24 days, there will be interference. But in the newborn period, this gut of the newborn is sterile. Therefore, there's no enteric organism to compete with the multiplication of the OPV. That is one of the reasons. And the maternal IgA does not inhibit. Therefore, these are the reasons why you give it, and the VAP chances are very less. Okay, next question.
BCG vaccination in preterm infants born after 32 to 36 weeks gestation is considered safe and effective.
What's it?
Safe
Safe
and
and
effective.
effective. Previously, it was that by MAN2 conversion, by scar formation, and also other say, T cells, they have found that BCG can be given in preterm babies. We will come to that, a full discussion on preterm discussion. That's another topic which can be asked you as an essay or a short note, immunization of preterm. Because in your postgraduate classes, don't expect the immunization schedule to be asked. Don't expect a question like BCG vac. They will ask you some question which requires your attention more, like immunization of immunosuppressed, immunization in preterm, etc. That's one of the topic which you'll come to discuss. So it's safe and effective. Now you read what is given in the bracket.
BCG is the only
No,
only
no,
currently used human vaccine
no.
for which
Only what is there in the bracket. That is enough. I have
okay.
highlighted some.
A calmette-guerin vaccination at birth is in healthy preterm infants born after 32 to 36 weeks of gestation was found to be safe and effective. For BCG vaccination of very low birth weight and extremely low birth weight infants, there are insufficient data to assess safety, immunogenicity, and efficacy. Based on current evidence, early BCG vaccination is recommended in stable infants who are preterm or low birth weight.
Now, throughout the book, there's a vagueness by which the IAP states about newborn vaccination, preterm vaccination, etc. The million definitely about 32 weeks you are giving at birth. But generally, what happens is all the immunization. How is it given in our nursery? Is it given when the child is still there, or is given only at the time of discharge? Ashwati, Gopika, can you help Ashwati? What's the answer to that?
In the hospital itself, sir.
Therefore, before discharge, it is given, is it?
Before discharge. Yes, sir.
Before discharge, what I mean, not on the day of discharge. Suppose a baby is, say, 32 weeks and he is 1.2 kg or 1.3 kg, and you are keeping the patient there for another 2-3 weeks. Will you immunize him? Is the birth dose of BCG, OPV, and hepatitis B given? What is the practice? You have been there. Mohsen. Mohsen is there?
Sir.
Yes. When is the child who is 32 weeks old? Below 32 weeks, they are very ambiguous in this. It can be, whether it can be given in low birth weight or very low birth weight is not known. Generally, 32 weeks before people don't give. My question to you is straight. In our newborn nursery, is a patient who is born, say, 1 kg, but is 34 weeks or 32 weeks because he's small for date, given an immunization on day 1. That is the chronological age. Chronological age by which BCG, OPV, and hepatitis B are supposed to be given is day 0. Is it given or not given? My God. You are posted there. You are living inside the SCABU and you're not answering my question. Okay. Amal is there or not joined? Amal is not there. Okay. Because I am not knowing who is there in this. Okay. There are 6 participants. Let me see who are they. I can see Faris. Faris, you can't hide now. You tell me. Is it there or not? Is it given or not given? Because when you are, see, the idea of putting you in the hospital, making you work is to know what is happening here, and everything that is happening there, you must find out whether it's the right or wrong. If it is wrong, if you think it's something against what is being taught, you should immediately ask the nurse there. You ask the doctor there. Is this the way? Because I read in IAP it should be given. How is it being given? What is the right? Keep on asking this question to yourself till you end your practice. Even now, I am asking myself, am I doing the right thing or not? Okay, my screen. Now, can you see my screen? Okay. Well, we will come into newborn vaccination and preterm vaccination, etc. It is said that it has to be given at chronological age. But generally, neonatologists would, all the Western books I have read were very clear in this. They were saying that it has to be on chronological age, it has to be given at birth. All the vaccines, IAP has given a separate chapter on preterm immunization. They are vague. They said it can be given as per chronological age at the time of discharge. That is not correct. A child may be in the hospital for 2 months. It's not chronological age at the time of discharge. Therefore, mind you one thing, doctor, please, PGs, if you are taken through the newborn ward and the examiner asks you, when do you give immunization? And you answer like this, well, it will be it will show very, very badly. The answer to it is you must say that basically it is given at birth, in chronological age. BCG can given at birth. For hepatitis B, if the mother is positive, it has to be given, but it is not counted. We will come to that discuss. OPV definitely given. One virus, which is even if the child is 6 weeks old, we won't give is rotavirus. Previously in America, they never used to, when they were giving OPV in the Western world, they never used to give inside the nursery because they thought it might circulate and cause problems. But here we can give. But the practice is in most of the hospitals, neonatologists give at the time of discharge. Now, you please find out in the next class, I will ask you this question. When are they giving? Okay. A little disappointed by your not answering this very simple question. Let me, 1 minute, it's gone off the, where is it? You're seeing my screen, is it not? I am not seeing my screen. Meeting information.
Not seeing.
Huh?
Not seeing, sir.
Not seeing, my God. Share. Plus MCQ. Where it went? PowerPoint. I'm again using it to share. You can see. I don't know what is that. You can see this share. Is it moving? No, I did something. Let me see. What did I do?
Change eyes.
But here the share is stopped. They are telling. I'll tell once more. I'll go to share screen. MCQ with answer. Let me see where PowerPoint is there. Something has gone wrong suddenly. Screen 1, screen 2. I'll start from the beginning, I think. No, I don't know all the meeting cancer. How do I'm losing time today. Terrible. WhatsApp, application. Images will work when you're recording the meeting. Okay. Because I'm recording, I think I shouldn't. Okay. You can't minimize, it says. How do I go to a desktop and open the thing? That's what I'm looking at. Let me see whether I can share. Screen 1 application free. Okay, now it should come. How's the patient in the emergency? Is okay. We went up to 24. We'll go down. Can we go through? Yeah. 27. All right, let me see whether I can go into. Can you see anything now? Hello? Can you hear me?
Yes, sir.
Can you see the screen?
Yes, sir.
Okay. Did it move now?
Phone. Yeah, sir.
Huh?
Yes, phone. Yes, sir.
35 it is now, is it?
Yes.
Can you read it now? I don't understand.
BCG revaccination is not recommended because
Yeah.
there is no proven benefit. There is proven benefit.
Yeah, there's no proven benefit. See, BCG vaccination given at birth, there are many points which I said we don't look for the scar, we don't repeat the vaccination. Maximum age you give is 5 years. Okay, now we will go to there's no proven benefit. Now, if you look at the slide, can you read what is given? You may,
BCG revaccine.
yeah,
Studies have shown minimal or no evidence of any additional benefit of repeat BCG vaccination against TB or leprosy. Therefore, revaccination is not recommended even if the TST reaction or result of an IGRA is negative.
the absence of BCG scar also you can read.
Absence of BCG scar after vaccination is not indicated of lack of protection and is not an indication for revaccination.
Okay, that's over.
Based
Now,
on limited available
that's enough.
evidence.
That's enough. That's okay. Yeah. What about the next question?
According to IAP guidelines, BCG can be administered up to what age? BCG.
I think I
1 year,
told
5
the
years.
answer half a minute ago. Paris, you're not there. I just said about it 2 minutes ago.
5 years.
5 years. Very good. It's Gopika, huh? Who is it? Okay. Now, what's the next one?
The preferred schedule for hepatitis B vaccination series in combination vaccination is 0, 1, 6. Actually, birth 0, 10, 14 weeks.
What is it? Preferred.
Birth 0, 10, 14.
Yeah, this is a problem, when they take the MCQ from which book it differs. Because for us it is 01. We are giving it at 0, 6 weeks,
10 and 14.
14 weeks. But here the answer question was the preferred schedule, and that is not there. Birth 6, 10, and 14 weeks is what we are giving. Is it the preferred dose? That's the answer. Becomes a little complicated. They are talking it is 0 to 4 and 6 months because the answer is taken from Nelson. Nelson will give the best one. Therefore, we can skip it. These are problems inherent in MCQs. If you have negative marks, you must better leave it, even if you know the answer. Because definitely the preferred route is not birth 6, 10, and 14 weeks because we are not giving the last dose on 6 months. We have to give the last dose on 6 months. Before that, it is not evidence-based. What we are doing in the universal immunization as well as in our private practice is not correct, but we are giving a booster dose at 1.5 years. We have discussed this in the last meeting. What about this?
The WHO recommended minimal interval between first and second dose of hepatitis B vaccine is 6 weeks.
Minimum interval, read it very carefully.
Minimal interval. 4 weeks.
Always read the stem carefully. Minimum interval. Minimum interval kill
0.
vaccine will be 4 weeks. You understand?
Yes.
Okay. Next.
MMR vaccine is most effective when given within how many hours of measles exposure?
Can you say? Why is it?
48 hours.
Yeah,
48.
I think it's 72 hours. You see, this is important because why why this is a little important to you is you have a child who has come to you, say, 1.5 years with or 2 years with measles, and you have a 6-month-old baby who is not immunized. You can give immunization at the age of 6 months for measles if there is an emergency, and there's an emergency you can give. If you are giving within 72, only thing you have to repeat the dose at 9 months or do the titer. Now, therefore, in this particular, therefore, this is something very practically important. In fact, in SIT hospital previously, when there were measles epidemics, always admission to the hospital was a threat for children. And there were surgery children like interception who got admitted, had the interception corrected, developed measles, and died because it's a devastating disease when you have a overlying medical or surgical problem. Therefore, in fact, I wanted to take up a thesis and say every admitted child who has not immunized, give measles vaccine and see whether it protects them. Because we considered admission to SAT as a criteria, as a something which is indicates exposure to measles. But anyway, this is something you should know that if you have in your practice, you have a 3-year-old child unimmunized, like we had when I came here, a 9-year-old child who had measles. And we never asked the mother whether there is anybody else in the family who's in the house. If there is somebody else, you can give the measles vaccination straight away because it might protect him. The measles vaccine, even after exposure, will protect the child against measles because the incubation period of measles is somewhere in between 10 to 21 days or something. The vaccine acts faster than that. Yeah, read that what is given here. Can you read it?
The MMR vaccine, if administered within 72 hours after exposure to susceptible individuals, identify measles disease, and it is the intervention of choice for post-exposure prophylaxis in immunocompetent host. Post-exposure prophylaxis is not of much benefit against mumps and rubella. Incubation period, measles 8 to 12 days. Rubella, the incubation period following respiratory exposure averaged 14 days with a range from 12 to 23 days. Mumps ranges from 12 to 25 days, but it is usually 16 to 18 days.
Therefore, it is not just a question of incubation period, how fast your vaccine acts also. Therefore, measles alone, when given after exposure, may prevent or modify the measles. But it's not MMR giving it doesn't modify. If you give a patient vaccination because he's exposed to mumps or rubella, it may not act that much. That must be information to you. Okay. Therefore, just now we discussed it. Therefore, what it is, incubation period of measles is approximately. Slight change. What is the answer? 40. Hello? Why you're not answering, or is a slide not change? What's the problem? Hello? You are there or?
Incubation period of measles is approximately 8 to 12 days.
8 to 12 days. Why this delay? Is it because the slide did not change or what? Therefore, we have written the answer is 8 to 12 days. I hope it changed, is it not? Okay. Now again, I am emphasizing you read it already. Therefore, I am just going through the incubation period. We already said this. Now the next question.
IFP recommend the second dose of varicella vaccine be given how many months after the first dose? 3 to 6 months.
Okay. Now, please understand one thing. We have understood that if we are giving the last dose is a booster dose. Now, in varicella is a live vaccine, therefore it's not a booster dose. It's either you take it to the first dose is effective or not. It is a primary vaccine failure for which you are basically giving it. Now, normally the interval would be very nice if it is 6 months. Therefore, if you have viruses like human papilloma virus was unlikely to be that the child to get it again. You may give it after 6 months might be the ideal one. But for varicella, because the chances are that if there is a vaccine failure, the child may get very one you give within 3 to 6 months can be given. Yeah, look, purple book is 3 to 6 months. Okay. Can you read it now? Okay, is the Ashwati, can you read?
The
Yeah, Faris, you can read, no problem. You read.
ACIP now recommends 2 doses of varicella vaccine for children of all age group. For primary immunization, the first dose is best administered at 15 months and the second dose should be given 3 to 6 months after the first dose. However, during an outbreak, the first dose may be administered at 12 months of age if it is ensured that the 2-dose schedule will be completed by the individual child. The second dose may be administered anytime 3 months after the first dose. For catch-up vaccination, children below the age of 13 years should receive 2 doses 3 months apart, and those aged 13 years or more should receive 2 doses at an interval of 4 to 8 weeks.
Why are they telling that above the age of 13 years, you should give it 4 to 8 weeks interval? And the other, below the age of 13 years, you give 3 months interval. Well, I can only speculate. The answer to it is that adolescents, when they go to school, when they go to boarding school, when they go to picnics, etc., are more likely to get it. Now, how can you give 2 viral? Why don't you wait? It is not a booster dose. The second dose is not a booster, so that you have to wait for 3 months or 6 months. Therefore, you can give it 2 viral vaccines can be given 4 weeks apart. Therefore, if the first one fails, the second one will act. And we want protection quick and fast above 13 years. That's why you can give at 13. And during an outbreak, you can give at the age of 12 months. This is very important to remember. During an outbreak, measles can be given at 6 months. Viral hepatitis normally 15 months. During an outbreak, 12 months. These are things which you should know. Okay.
All high-risk children should, however, receive 2 doses 4 to 8 weeks apart, irrespective of age.
This is important because you are diagnosing a nephrotic syndrome. You're going to start him on steroids. Varicella vaccine, have you ever thought of? If you are going to nephrology, Mohsin, you must tell say, please, doctors, give Morzella vaccine. And if you can wait for 4 weeks, you can definitely give the second dose also. But normally you can't wait for 4 weeks before you start the steroid treatment. 2 weeks is the maximum the nephrologist will wait. Therefore, you can give the vaccine and then after 2 weeks, start the steroids. That will be a good thing to do if the patient has not received varicella vaccine and does not have antibody titer to it. These are every point in immunization is important from the practical point of view. It may not be so important in a government service where you see paid, but in private practice or in real quality service you want to give to your patient, these things will come up. I don't know how much of you, if ever you have seen a nephrotic syndrome, if anybody, pediatrician or somebody has started steroids, has he ever thought of varicella vaccine? If he has not, it is not a very good thing, because chicken pox in an immunosuppressed patient can be devastating. Okay. Can you read it?
The preferred typhoid vaccine for the use in children under 2 years of age.
Oh. Quick.
Conjugate vaccine.
Very good. That's it. No, I don't want to say.
Quadrivalent HPV vaccine protect against which type of HPV? HPV 6, 11, 16, 18.
6, 11, 16, 18. Actually, we should learn human power vaccine. Remember, we have gone through only the immunology, the detail of each vaccine you should know. I said last week that I'll give you the names. Today, I will send you you will have to prepare certain things. I will have to prepare certain vaccines. Okay, now the answer is 6, 11, 16, and 18. Now, therefore, the HPV vaccine content, we have Gardasil 4, Gardasil 9, and Cerovac. I think Cerovac is no longer available. 4-valent vaccine and 9-valent vaccine are available. But 9-valent is definitely superior, but it is very costly, 9,000 or 10,000 rupees, while the Gardasil is 4,000 or 5,000 rupees. Anyway, we will come to that later. Okay.
The WHO recommended minimum interval between dose of HPV vaccine in a 2 schedule is 6 months.
6 months. Is a killed vaccine or live vaccine?
HPV. Killed vaccine.
Killed vaccine. Subunit vaccine, if I remember rightly. Therefore, we will be reading it. Why is it 6 months then? Because the chances, we want the maximum booster effect to come, the memory B cells, and the chances of him getting reinfected within that time is also less. And nowadays, HPV, they are telling even 1 dose is enough. Okay, 6 months. Read it.
The minimum interval between first and second dose is 6 months. A 12-month schedule result in higher GMTs and is suggested for
Programmatic
programmatic
and efficiency. Yeah, okay.
and efficiency reasons. There is no maximum recommended interval between dose, and longer intervals up to 3 or 5 years can be considered if useful from a program perspective.
Now, let me tell you one thing that many pay different. For example, the varicella vaccine, we give at 15 months, we give at 18 months. That's because we don't want children to develop chicken pox in young age. But in Western countries, they give the second dose in school entry. Remember this. They don't give it. Therefore, school entry is a very important point because we want them, there's the chance of getting chicken pox at that time.
A single dose of HPV vaccine may
There's a new thing in can we give a single dose? The main reason is cost. Which is the, can you tell me? Uh, maybe an off-label based on evidence showing better affordability, I thought, but the answer they have given is similar protection as a multi-dose regime, because there is something, this is a new thing, it is coming up in journals, it is editorial in some of the New England journals, single dose enough or not. And recently, therefore, you must know what exactly the WHO position paper says on single dose. This can be what you call latest advance in medicine or something. Can you read the whole thing now?
Alternative single-dose schedule. As an off-label option, a single-dose schedule can be used in a girl and boy aged 9 to 20 years. Data from immunogenicity trials, post-hoc analysis of efficiency trials, and post-licensure
Observation studies. Yeah.
observational studies among females have demonstrated that single dose of HPV vaccine is sufficient to elicit an immune response that provides a similar protection as multi-dose regime against initial and persistent HPV infection. This may offer program advantages, be more efficient and affordable, and contributes to improved coverage. From a public health
Hello, what happened? I can't hear.
no current evidence of this.
In between, I couldn't hear. From a public health perspective, the use of a single dose schedule can offer substantial benefits that outweigh the potential risk of a lower level of protection if efficiency wanes over time, although there's no current evidence of this. Here, there is a statement in the in between, if you can, I can point the laser, demonstrates that the single dose is sufficient to elicit immunity, provides similar protection as a multi-dose regime, okay, against initial and persistent HPV infection. That's what they used it in the MCQ. Therefore, a single dose, it produces similar and a multi as a the similar protection as a multi-dose regime, initial and persistent. That's what they are telling. Therefore, but still the WHO as well as ours is 3 doses. I think 2 doses before 9 to 15 years, and above 15 years is 3 doses. But even a single dose, 9,000 rupees may be good enough. Can you read the next one? Yes. Read the question, please. Ashwati, can you read?
Genetic variability
Yeah.
in which module significantly affect T cell response to vaccine?
The antigen or the parasite is held in the major histocompatibility.
Recording in progress.
Yeah, we know recording is in progress. Which one? Which one is the answer? I can't hear very well. Can somebody else talk, or you can talk? Gopika, are you there? I think there's some problem in the library. I can't hear what they are reading. Gopika is left out. Gopika, are you there?
Hello, sir.
I can't hear you well. Who's speaking?
Faris, sir.
Okay, you mute the others. Faris, you can. Which is the answer now? 47.
Major system complex.
Yeah. Okay. Now, I think too many mics are on. That's why echo is coming. Please. Okay.
Unmuted, sir.
Okay. Read the slide has changed. Read it now.
Genetic factors. The capacity of an antigen epitopes to assess the large panel of MHC molecules increases the likelihood of response in population. MHC restriction may limit T cell response. Gene polymorphisms in molecules critical for B and T cell activation differentiation are likely to affect antibody response. T cell response differ markedly between individuals and populations because of genetic variability of MHC molecules, that is human leukocyte antigen A2, HLA-A2.
Okay, therefore that's what the answer, because based on the histocompatibility, your T cell response may vary. That's the answer. Okay.
The presence of maternal antibody has the greatest inhibitory effect on which type of vaccine?
Yes.
Greatest inhibitory effect.
That is the maternal greatest inhibitory effect on which type of vaccine?
Live,
Yeah, live attenuated vaccine, because it is, we said that very clearly. That is why even we are afraid when we give a MMR at 9 months, we repeat it at 15 months. The live vaccine are exclusively sensitive to maternal antibodies. Read the what is given in this one.
The inhibitory influences of maternal antibodies on the infant B cell response affect all vaccine type, although its influences is more markedly for live attenuated viral vaccine that may be neutralized by even minute amount of
Minute amount.
minute amount of passive antibody. Hence, antibody response elicited in early life or in short lasting.
Okay, viral vaccine. Therefore, we are afraid to give. The earliest viral vaccine we give is 9 months, and we repeat it at for MMR. While in other countries, they will not give it before 1 year. And during an epidemic, of course, we give measles at 6 months, knowing fully well it may not act.
Isotope switching and somatic hyper mutation occur even in infancy but require several months for full maturation, resulting in
A little tough question. Therefore, isotype switching and somatic hypermutation occur early, even in infancy, but require several months for full maturation, resulting in that is, the answer is, I think, delayed high affinity responses. Delayed high affinity responses taken from podcasts may not be so important. Can you read what's given in the bracket?
vaccine response at the extremes of age, the challenges of neonatal and early life immunization, isotype switching, and somatic hypermutation, that is, the affinity maturation of vaccine-induced B cells, are already functional in the first year of life, including in preterm infants.
Okay, including in preterm infants. Therefore, now the last question, I think.
The main reason for administering a booster dose at 15 to 18 months is to achieve long-term durable
Immunity, long-term durable immunity. That's given. And see, the booster dose can be given at 1.5 years, because in infancy, maybe the germinal center, the T cell, etc., are not properly developed. Therefore, this is given in the purple book itself. Just read what is given in the bracket.
However, a booster at 15 to 18 months is required for durable immunity.
Okay, that is actually what happens is some of the boosters you can give at 9 months also. We are giving, for example, pneumococcal vaccine. The dose is, I think, 6 weeks, 14 in the universal immunization. In the government sector, it is 6, 14 weeks, and 9 months. Therefore, the booster, the last dose is given at 9 months. 9 months is the earliest time at which you can give the last dose. From 9 months onwards, the booster is advised because you want to give it early. But generally, we would like to give it at the after infancy, 15 to 18 months. Therefore, if you are given the full primary doses, that is why pneumococcal vaccine in 3+1 schedule is considered the best. And that is what the IAP advises. And that is what you should follow when the patient can afford 6, 10, 14 weeks and 1.5 years. But at the same time, somebody can ask you, why is it 2+1? It's the second best. It is not, because at the end of the day, if a booster is given from basic immunology, beyond infancy, it has a longer acting. Now I will end the show and go back to, for the MCQs on video 2 are over. MCQ and answers on video 2 are over. And we will go to video 3 and we'll look at the questions this time. This is not the, therefore I'll stop the share and now I will try to. I'll upload the other answer, then we'll start immunology. Video 3 we had done up to, I'll tell you what, see, we are talking of immunology of the vaccination. We are not going into the vaccine in full detail. And this is, we have discussed most of the vaccine like meningococcal, rotavirus, etc. But what we have to, there are few, we will just be sharing a little. I'll talk about rabies vaccine and then 1 or 2 slides about rabies vaccine, and then we will go into certain other topics of interest. That will be maternal vaccination and pulse polio. At least I plan to finish these things, but already time is not in our hands, I think. You can see this slide.
Yes, sir.
Rabies vaccine, you can see, is it not? Okay, that's good.
Yes, sir.
Now the point is that normally, what I had killed the vaccine, if you give today DPT, the next dose can be given after 4 weeks. We have seen it. Rabies vaccine, is it a killed or a dead vaccine? Simple question. I think most of the people have left. What happened? There are only 4 participants now.
Yeah.
Okay. Who is there? Faris is there. Who is there in the library? Amal is there? No.
Amal PSC.
Yes, you can log in from there. Ashwati is there?
No, Mohsin is there.
Huh?
Mohsin is there.
Mohsin and Faris are there. Okay, only 2 people now. Okay, that's what the class is ending up in. Okay, because when are you going for the marriage? Today evening or
Today evening, sir. We are going today evening.
at what time?
Train evening ആണ് സാർ. ഞങ്ങള് 2 days കഴിഞ്ഞിട്ടാ പോന്നെ. ബാക്കി ലേഡീസ് എല്ലാരും ഇന്ന് പോകും.
In the home, well, okay, now let's me start the recording. I think I didn't record it. Did I record it? talking. What happened to Zoom? It's not. I must record it, otherwise. Yeah. Share, move. So it is still recording. It is recording. I didn't stop the recording, I think. Okay. Then now you can see the slide. Am I right?
Yes, sir.
Okay. Now, I asked you a fundamental question. Is the rabies vaccine live or a killed vaccine? Is a viral vaccine?
Mm.
See, this is the, I'll go through it very fast. Why I asked this question is human diploid cell contains flurry of rabies in ultrafiltration and inactivated vaccine. And the purified chick embryo vaccine, 2 vaccines are available, is also inactivated. Therefore, remember, it's basically a inactivated vaccine. Therefore, I was worried, I was wondering, how come then you are giving it 0, 3, 7, 14, 21, 28 like that, a killed vaccine? I couldn't find an answer to it. And I finally looked up at the AI to give me an answer, but it didn't give me a clear answer. It said can you read this? The accelerated schedule for rabies vaccine is scientifically justified by the need for rapid immune response. That is not a correct answer, because how can you get a rapid immune response if you give? So then you would be giving in other vaccine also. The nature of inactivated vaccine requiring multiple doses, evidence of immunological study showing robust antibody kinetics, available HIRIG to bridge the gap until active immunity develops. The approach ensures maximum protection before the virus can cause irreversible damage. See, what they are telling is in rabies is a life and death issue. It's a fight. You want to prevent the virus from entering the neurons. Therefore, that's why you are giving multiple killed vaccine at short intervals. But immunologically, basically, it doesn't explain the reason anyway, but understand. Okay, that's it. Now, regarding maternal immunization is what we are going into. My question to you is, many of our gynecologists, some of them give maternal. In fact, our nurse in charge of the pediatric immunization previously, Sheba, she came to me and said, Doctor, some gynecologists are giving TDAP, some are not giving maternal TDAP. Can you talk to them and make them all give? And when I told to Dr. Ananda, Madam was also not very much in favor of giving TDAP, because TDAP is about 1,200 or something, while TD is much more less. You know that tetanus is no longer available, only TD is available. Now, what do you think, Faris, is antenatal TDAP indicated in our patients or not?
Indicated.
Indicates. Is there any point against giving it? Why are some gynecologists worried? Mohsin,
SLR pertussis and the complications.
yeah, that's a plus
Can
point. That's a plus point for which you are giving, because pertussis can occur even in newborn. And by the time you give newborn immunization to a child at 6 weeks, it may take another 6 weeks for immunity to come. And therefore, he's unprotected at the most difficult period. And pertussis in newborn is a very, very dangerous disease and carries a high mortality even in the Western world. Now, my question to you is there anything that keeps you from giving TDAP? Maternal immunization in general. What are the vaccine you give in maternal immunization? Suppose you
TD.
are
TD?
what's that?
TD, sir.
TD.
Yeah, that is same, isn't it? TDAP and TD. You give one dose of TDAP and the other is TD. That's how you give. We'll come into it. What is the other one which you give? Any other vaccine is advised? Well, what's the problem? Any other vaccine is advised? Okay, we will read through the maternal immunization very fast. You have to know about it. Don't think it is a gynecologist problem. They would come and ask you. Number one. Number two, if they are doing something wrong, you can have a chat with them because the children are here. The reason. Okay, now carry on. Okay, read it now.
Live vaccines are immunization in pregnancy. Live vaccines are generally contraindicated in pregnant women. The yellow fever vaccine should be avoided in pregnant women as far as possible. However, if a travel is unavoidable, the vaccine should be given as the risk of infection outweighs the risk of vaccination, probably in first trimester. Measles, MMR, varicella vaccines are contraindicated in pregnancy, and pregnancy should be avoided for 4 weeks.
I can't hear you, Paris. Hello.
Yes, sir. However,
Yeah, read it.
routine testing for pregnancy prior to immunization with this vaccine is not recommended. If the vaccine is inadvertently given during the pregnancy or pregnancy occur within 4 weeks of vaccination, termination of pregnancy is not warranted.
Please mute one of your.
Small cohort studies shows no increased rates of congenital abnormalities in infants born to mother inadvertently vaccinated in pregnancy. Measles, MMR, varicella vaccines can be safely given to contact of pregnant women as these vaccines do not spread from vaccine to contacts.
The last one. As the last line comes. Smallpox vaccine is the only vaccine known to be harmful to the fetus. Now we know that, see, the live vaccines are contraindicated in pregnant women. But sometimes there will be a problem because international travel, yellow vaccine is required when you go to African countries. From African countries, if they are coming here, they should be given. It's better to postpone the travel. If they cannot, then you'll have to give the vaccine. Now, MMR, measles, and varicella is something very interesting because if you have given the vaccine, pregnancy should be postponed by 4 weeks. But sometimes, you may not know. The mother may be pregnant and you may give the MMR for some reason. And then she will come back and report to you, I'm pregnant. But you need not be worried about it. The pregnancy can continue. That's what they say. And contact with pregnant. Therefore, all these points are very important. During pregnancy, MMR should not be given. Okay, that's very clear. Therefore, that is why if the pre-pregnancy itself, is better to test the titers and give the MMR vaccine to girls who will not become pregnant in the next 4 weeks. These things may not look, but if you have seen a congenital rubella syndrome with a microcephaly, with a cataract and mental retardation, and known fully well this could have been prevented if only the mother had been done the rubella anti-titer before her delivery and given rubella vaccine. It is something which is lifelong they will carry. Therefore, these things, as pediatricians, you should consider. Suppose somebody in Oman, it has become very common that before they get married, they go for premarital counseling and there is premarital medical checkup in which sickle cell disease, hemoglobin ultraforce is done, and also the antibodies, if I remember, they started doing. And then they are counseled if they are afterwards. Read the rest. Can you read?
Change.
If a change out, just wait a minute. See, when you read it, if you are reading from your phone, mute the laptop. Laptop is getting cut off, I think, in between. Has it changed? See in your phone. Hello?
Hello? Sir.
It is
All
echoing.
inactivated vaccine may be safely given during pregnancy. Important are TD, TT, Tdap vaccines. Okay.
If you cannot read from the laptop, please read from your phone after muting the laptop.
Sentence, sir.
Next sentence കാണാനില്ലേ? Can't you see that?
I can't.
Mohsen, you're there?
OT-ലാണ് CS attend ചെയ്തത്.
So there's only Faris now here.
Waiting for no.
Faris, can't you read? What's the problem?
The vaccine of important in the pregnant woman.
No, Faris, there is some problem. Okay, are you reading from the laptop or from your phone? Are you reading from your phone or from the laptop?
Hello, sir.
I can't hear you. Are you reading from the, are you in the library or where are you?
I'm in library, sir.
And are you reading from, because I can't hear you. Can you see the slide now? Only you are there. Nobody else is there. Am I right?
Yes, sir. For hepatitis B are other vaccines of importance in pregnant women. Pregnant women should not
Faris,
be
I'll do one
given
thing.
live attenuated.
Faris, I'll do one thing because you are the only person available. We'll close the meeting today and we'll try to, day after tomorrow, you are available or not available?
Available, sir.
We are going for the, this one, no?
Saturday going, sir.
Huh? Saturday?
Saturday
No, I'm just
going for
asking.
marriage.
You're going for marriage only.